Good afternoon, everyone. It is 12 o'clock on Friday, June 12th. Dr. Michelle Fiskus. I'm the Vaccine Preventable Diseases and Immunization Program Director at Tennessee Department of Health. And with me again, appropriately socially distanced, is our friend Dr. Kara Levinson, who's been with us before. She is the Deputy Director over at the State Public Health Lab, and we're going to spend some time talking about testing today and what testing does and doesn't help with and those kinds of things. So we're excited to have Dr. Levinson back again today. So we're going to invite you to get on to Menti again. So if you go to www.menti.com on any device, you can enter the code 389028 and start entering answers to these polling questions. It's nice to have an opportunity to engage with you guys a little bit. Since you can't talk to us out loud, it's nice to get some information from you. So we've asked for one word that is clean enough to put on a state government webinar to describe this pandemic. And so we'll have, probably 6 or so questions here today, and you can go through those ahead of what we're doing. You don't have to wait for the webinar to go on. I totally agree with that surreal comment that just came up, and exhausting. It is just something unlike anything that any of us have really ever had to deal with. So we feel all of that angst that's there. So exhausting, confusing, roller coaster, ever-changing, scary, division, surreal, yeah, all of those things for sure. So question for you, why is it called the novel coronavirus? Because it's a long, long story, but I'm here all week. All right, just getting warmed up. So every week we ask who you are, and so if you can go back to Menti and that next question, answer who you are, Menti.com, enter the code 389028. And this will populate as more folks hop onto the webinar today. But typically what we've seen is half pediatricians, half grown-up doctors, and a smattering of other folks. It's awesome to see some folks from College Health on here listening this week. We've had some conversations with a lot of folks in College Health over the last week or so as they start to think about how they're going to transition back to opening colleges. Some students are already going back because college football is already starting preconditioning, and so it's kind of a scary thought to think about kids already arriving back on campus when we're continuing to see numbers moving the way they are across the state and across the country, and it's, I'm for one pretty nervous to see what's going to happen as we start bringing kids from all over the country to all the different parts of the country and what might happen as a result of that. So keep on entering into these questions at Menti.com 389028 as we go on. So the other thing I'd like to know is, have you attended these Friday updates before? I know we have a lot of folks that do come on week after week, which is great, and that tells us that the information that we're providing is helpful to you. You all are incredibly busy, and so the fact that that you've come on over and over again, the vast majority of you, is wonderful. And as always, at the end of this, at the very last Menti slide that you have, we'll ask for topics that you'd like us to cover, and we really do look at that list and try to make this what you want it to be every week, so that we can give you an hour of a quick update on all things coronavirus related in Tennessee, and maybe save you a little bit of trouble in trying to figure things out on your own. So it's great that almost 3/4 of you have been here before. And then on a scale of 1 to 5, how is your stress level? 1 being I'm good, 2 is I'm stressed, but it's manageable. 3, I'm pretty stressed. 4, it's starting to take a toll. I'm sorry, 4 is I'm really stressed, and 5 is it's bad, and I feel hopeless. And so we're starting to see these numbers a little more across the board now than what we used to see. So still, the majority of folks are saying that they're either good or stressed but doing okay, but almost half of us now are getting to the point where it's really starting to take a toll, and we feel that. We certainly feel that here at State Department of Health with all that's happening and all the things that we're looking at trying to juggle, so we know that it's really hard for all of you as well. Just for comparison, so take a look at this slide right now. So pretty evenly spread over at least 1, 3, and 4. This is how we were in April 24th. And at that time, I had this slide set according to the breakdown of professions, but we have certainly moved in a difficult direction, and everybody is tired and stressed out. And I think we've continued to watch these numbers over the last 3 months or so since we've been doing these, and appreciate the toll that it's taking. I always like to remind folks of the physician support line that is up. There are over 600 psychiatrists who volunteer their time specifically to talk to physicians who might be having some difficulty coping with all of this. And so these folks are there from 8 in the morning till 3 a.m., 7 days a week to take calls. There have got to be some real insomniac psychiatrists, I guess, that are up talking to people till 3 in the morning. But that number is 888-409-0141 if you find that you just need to be able to get some of this out. So here we are, and we set up this incident command system here at Tennessee Department of Health in our Health Operations Center, State Health Operations Center, or the SHOC, on January 15th. So that was 149 days ago, and today is our 99th day since the first case was identified, and it has been one heck of a 99 days. We still have our clinician call line that operates during the day, and that number is 615-741-7247. And then overnight, you can also call if you have clinical questions, if you're a physician and need to talk to one of the state Department of Health physicians here. We all rotate through call each week or so, and that is available 24/7. So that's for rabies bites or dog bites where you're considering rabies or carbon monoxide exposures or whatever. We're available to help with that. The global statistics, I started putting up just a week prior I think it's so easy to lose perspective in this and forget how quickly this is going. So, we're at almost an increase of nearly 1 million cases in the world over the last week, and 20-some thousand deaths, 30,000 deaths since last week, since last Friday. And then this is the global epi curve, and notice that the scale changes by about 50,000 every week as we march on through this. So this isn't the cumulative case count. This is the daily cases that are being reported that, we are now heading towards 200,000 cases per day that are being reported in the world. In the United States, we've gone from 1.8 million cases last week to over 2 million cases this week, gained another 5,700 deaths. And you can see the epi curve. So the United States is the orange one that is downtrending, but maybe starting to plateau there a little bit over the last couple of weeks. The green curve is Brazil, which is in a whole lot of trouble right now. And then the other countries that are really starting to see an uptick are India, Pakistan, Chile, and Mexico. Those are all beginning their part of this whole pandemic now and moving in a really upward trend, especially Brazil. Brazil has been hit really hard over the last couple of months now, and is having some significant problems there. And then when we look at the state view of this, this is still my favorite data slide that Johns Hopkins puts out. I just love this. So Tennessee is actually a little less pink than it was last week by Johns Hopkins calculations. So you can see the states that have seemed to have moved well beyond their initial, what might be a first phase or who knows of this pandemic. And then there are a lot of states that are still sort of plodding along here. But notice our border states, how most of them are pretty pink. And, this isn't a virus that understands boundaries or state lines. And so it's a little bit scary when we're starting to see states that are around us that are really starting to have some problems. This is what our state epi curve has looked like. So you can see where the stay-at-home order expired at the end of April, and then we had a drop to our lowest positivity rate, which was around May 10th of 3.6%, and then we had this really steady climb over up until last week, and now this last week or so we've looked to have plateaued at about 5.5% positivity. The WHO would really like to see countries below 5%, and then that increase in cases that may have been a reflection of things like Memorial Day. We probably aren't seeing numbers increasing that might come out of things like the protests or the continued opening of venues around the state. So it'll be interesting to see if we're able to maintain this plateau that's showing up for the last week, or if we're going to start having an increased number of positive cases. So this is the 7-day moving average of positive tests. And I just wanted to give you a little bit of comparison for some of the states that are around us. So Alabama is in really bad shape right now. The city of Montgomery is about out of hospital beds and moving into surge. They've got 22% of their tests being positive at this point, and really moving into a place where they're going to be struggling over the next few weeks until they can get this under control. Likewise, Arkansas at 33.6% positivity for their cases. Georgia, there had been a lot of talk about Georgia because they had some early reopening. They are moving in the wrong direction, but their positive rates are still fairly low. Their testing is also a little bit low compared to a lot of the other states, but we'll keep an eye on Georgia. Mississippi, 18.6% positive. Kentucky is the best among us, and I hate to say that because I'm from Indiana, and for me to ever admit that anything Kentucky is good is a struggle for me. But it's at 2.7%. Missouri looks good. North Carolina is increasing, and about in the same boat that we are. South Carolina I threw in just because they're one of the worst states in the country right now with respect to their rapid increase in cases. I think yesterday they had a record for their new positive cases. Virginia is at about 9% right now, but moving up, and there we are at 6% in Tennessee, but also moving up. And then I just wanted to point out New York. Considering what New York went through and the just absolute devastation of their numbers of cases, their numbers of deaths, to have an epi curve that looks like this and to be down close to 1.3 or close to 1% positive and downtrending is just amazing to me that that they've been able to get around this pandemic in New York and really start to to come out of this. Now, as travel starts to increase and we start having people going from states that are not under control to states that are under control, we're going to start to see all of this mix up again, and really have concerns about where we're going to be over the next few months. As far as testing goes, we're still sitting at 13th in the United States. We've been here for the last couple of weeks with about 7,800 tests per 100,000 people, 413 cases per 100,000 people, and 6.5 deaths per 100,000 people. That death rate is up a little bit. And we've just crossed 500,000 tests that have been done in the state of Tennessee since the beginning of this. You can go onto our website at tn.gov/health to see the daily case counts, and they add new data, not just updated data, but new data every week or so to our website. So it's worth going on and nosing around and seeing what's on there. We're up a little over 3,000 cases over the last week and 40 deaths. And the hot spots remain Metro Nashville, Metro Shelby County, where Memphis is. There's a lot of activity in the Rutherford County, Williamson County, Sumner County areas, and then a lot going on around Chattanooga. And this is the confirmed cases for 10,000 residents in Tennessee by zip code. And you can see where you drill down a little bit to where some of those hot spots are. And then our epi curve on the bottom there, which tends to continue to move up over time. We'd really like to start to see that plateau, but we've just not seen that happen yet. Some folks have asked about hospitalization numbers. So this is available on our website now too at tn.gov/health. So this is the number of positive cases each day, the daily count. You see a big uptick of hospitalizations of COVID-19 patients in Tennessee. And this is what the bed counts look like. So available floor beds are at 19% across the state, and there's variation across the state from region to region. ICU beds are at 17%. And you can see this big uptick in inpatients, this little uptick in ICU patients, and maybe a little uptick in the numbers ventilated. We were pretty solidly in the 60s for the numbers ventilated for the last several weeks. So up into the 70s now with that, and our inpatient numbers had been hovering about 300, but we're getting on close to 400 now at this point. So the state has stood up their two alternative care sites, one in Memphis at one of the old newspaper factories that has been completely remodeled by the Army Corps of Engineers to be, I think, a 400-bed hospital. The second is a unit that's been put up in Nashville General so that they can put COVID-19 patients in those facilities if we should have a surge. And those are standing empty at this point, so we're not having to use those yet. We've had about 7.5% of our population tested so far with a death rate of 2%, but that death rate is 9% if you're over the age of 61. So if you have patients that are 61 and over, they have almost a 1 in 10 chance of not surviving COVID-19. If they're in a long-term care facility, it's closer to 12% risk of fatality in those centers, and 84% of our deaths are in those ages 61 and older. And then we're continuing to see the numbers of cases in children and adolescents grow. These tick up by about 1% every week over the last 3 weeks or so. So now at 4% of the cases in young children, 9% in adolescents. I wanted to remind you of the MISC case definition. So this is the multi-inflammatory system, multi-system inflammatory syndrome in children that's associated with COVID-19. And this is a reportable condition in the state of Tennessee. So if you should have a patient who's under the age of 21 who's been febrile and has elevated inflammatory markers and multi-system organ involvement, and that can mean a rash plus something else, and there's no evidence of an alternative diagnosis, then we do need you to report those cases to the state so we can investigate them, and you can send those to amanda.hartley@tn.gov. And some recent headlines, so some of you may have seen, especially on social media, the WHO saying that it wasn't very likely for asymptomatic people to be spreading COVID-19. Then they had to quickly come back and retract that statement because there is a difference between asymptomatic and pre-symptomatic. So Dr. Fauci released this. What happened the other day is that a member of the WHO was saying that transmission that should be from an asymptomatic person to an uninfected person is, quote, very rare. They walk that back because there's no evidence to indicate that that's the case. So it's very difficult to know if someone who's asymptomatic currently is pre-symptomatic or is going to remain asymptomatic. Right now, the estimates of those who are asymptomatic and infected are as high as 40% in the United States. And then you may have seen in the governor's press briefing earlier this week that Tennessee is going to start allowing visitors into nursing homes again starting next Monday. There are some criteria that nursing homes have to adhere to for that. They have to have tested all of their staff and residents at least once, and then they have to have weekly retesting of staff. They can't have had a new COVID-19 case in a resident or a staff member in the past 28 days. They have to be in compliance with all of the licensing regulations and be in a community where there's overall stability of disease burden. And the Department of Health will be putting up a dashboard, hopefully in the next week or so, that will help counties understand where their disease burden is and whether this is a situation where they can think about their long-term care facilities opening or not. And I hope that that dashboard might be able to be used by school systems and colleges and other public places that might want to be informed by what the local transmission looks like. So Dr. Levins and I are going to talk a little bit about testing again, or a lot about testing again. It's always the most popular topic of conversation that we get here on these webinars. So we go over what's happening with testing emergency use authorization from FDA. So there are now 5 CLIA-waived molecular test platforms with an FDA emergency use authorization. The Abbott ID Now, which has had some early problems with
Ongoing problems
with sensitivity.
Correct. The last I heard is they're working on amending their EUA yet again.
Okay.
Such that a negative result should be considered presumptive and has to be followed up by another molecular test.
Oh, no.
So be on the lookout for that amendment.
Okay. So that's not great news. The Cepheid Gen Expert, which is, Cepheid is the platform, one of the major platforms that we use at the State Public Health Lab.
Correct.
And y'all have confidence in this platform.
Yes.
So there is a CLIA-waived version of this. It's pretty pricey. I think the base unit to run 2 tests at a time is about $16,000. The tests run about $50, $60 a piece, I think, somewhere in there.
Scalable, but
yeah, and they take about 45 minutes to run, so it's a little bit slow, but good results.
Yeah, and one benefit is we call this a plug-and-play test, and that it doesn't have a separate extraction step versus the PCR step. So you load the sample in, plug it in, and get a result in 45 minutes or so.
Yes, that is nice. And so obviously at State Lab, we don't run these 2 at a time.
Nope, we have ones that hold 48, and we've got 2 of them, and we'd love to get more. So
yeah, and so the big limiting step on Cepheid has been the cartridge availability because everybody wants them, and they only have just so many.
And for point-of-care testing, one thing that's helpful is Cepheid, once you get the instrument, the cartridges vary, so you can use the instrument for a variety of tests. I've seen it clinically used for flu and RSV, for Clostridium difficile. There's a variety of tests, so if you're looking to use COVID money, it would be a good instrument to be able to use right now and potentially into the future.
And Cepheid just released a press statement that they're coming out with a quad test that will run flu A, flu B, RSV, and COVID-19 all on one test. It is awaiting EUA right now, but
it'll be great for the fall. I know there's a variety of manufacturers that are looking at kind of multiplexing, flu, RSV, that kind of thing. All the fun respiratory viruses you see in the fall.
All the fun.
Yeah.
Mesa Biotech Acular, I don't know if you know anything more about this company, but we have had our procurement people call and just get shifted to a third party who doesn't answer the phone, and so I don't know what's happened to Mesa Biotech.
haven't heard anything, and I don't know anyone who has. So
interesting.
Take that with a grain of salt.
Yeah. And then Quidel, which many of you are probably familiar with the Quidel platform. They do a lot of antigen tests for strep and flu. They have a antigen test. This is not a PCR test. For COVID-19, it runs on with their Sophia 2 analyzer, so it's not one that you can read with the naked eye. You have to put it into an analyzer to be read, but it's quick, about 15 minutes. It's cheap. I think it's $26 a test, something like that. The analyzer runs about $1,200 and has a rechargeable battery, so you could take it, you know, I don't know if you needed to go do PCR or antigen testing somewhere. We're hoping to use it for testing some of our homeless population so that community health centers can go out literally into the field and help get people tested on site, and folks that we may not be able to find again to get, you know, the results of a 24-hour test back to them. And then you just told me last night that Q, who also makes antigen tests that a lot of physicians are probably familiar with, has just gotten EUA for their test.
Correct. So this is one, it's a little bit different from the other point-of-care waived tests in that it's a nasal swab you collect directly and immediately put it onto the cartridge, which goes into a reader, similar to other tests. But it's a little unique in that there isn't a screen or anything else you interact with. You actually have to download an app onto an iPhone, and that's where you put in the patient information, you scan the cartridge, and that's what actually gives you the results, positive, negative, invalid, etc. So I'm not quite sure how that would link up to like a medical record, but it's a little unique compared to the other, you know, readers that you might be using for other tests.
I wonder what their thought was around doing it that way.
It's very small and looks relatively portable, and you just have to pair it using Bluetooth to your phone once you plugged it in. So I think that would be a potential positive. It's also very quick. It takes about 25 minutes. To get a result. But the Q wand is a specific swab that you can only get from them? And you pretty much have to swab and immediately put it in within a couple minutes. Okay. And then there are several home collection tests that are available for consumers to procure. Most of these do require that you go online and fill out a questionnaire with your symptoms, your exposure. Although that seems to be loosening up somewhat. They consider exposure now to be having been in a group of 15 people or more. So there's that. And then they either spit in a tube or they swab their nose or their throat and send that in via FedEx. Most of these companies, from what I can tell, you have to get it back to them immediately. Like you have to mail it out the same day or it degrades quickly. And they're also not cheap for the most part. And then just a reminder that there are still no CLIA-waived serology test platforms with an FDA EUA. So if folks are using serology in an office setting, it is likely not one that, well, won't be one that has an FDA EUA. And you have to be careful. I've seen a lot of verbiage that says FDA authorized, and that can be used to mean they just let the FDA know they've made a test and they're distributing it. There's a clear distinction, and emergency use authorization is what you need to look for when it comes to or it'll say EUA filed or EUA pending, which none of that means anything except that the company did something. You can always go to the website and look up the list of EUAs that's updated daily. And the serology tests, many of them now on that website actually have the specs as far as sensitivity and specificity for the serology test. They don't list those yet for the molecular tests. I wish they would, especially for the CLIA ones. I can tell you a little bit about why, maybe. Oh, okay. I can do that when we get to the paper. Okay. I can do it now. I'll tell you. Okay, so one of the things that we wanted to talk about was this paper that came out in the New England Journal of Medicine this week on false negative tests for SARS-CoV-2 infection, challenges and implications. And I did know where this came out of, and now I've forgotten the university. I had it written down. Kara's looking it up. But this is a paper that was written, it's a perspective from these physicians and scientists about things to think about when ordering testing, specifically PCR testing. Yeah, it's one of those.
New Hampshire and Vermont.
East Coast.
East Coast. Some northeastern people wrote this perspective about, I don't know, I always find, I want context, like where did this come from? So anyway, for whatever that's worth, northeastern people wrote this, and so we wanted to go over this a little bit just to talk about some of the things to think about when you're getting these tests and maybe how they need to be couched to patients. So PCR tests are not perfect. We know that. There's so many different variables.
And really, no test is perfect.
True.
It's not just PCR. There's no test that has 100% sensitivity and 100% specificity.
And with this test, especially, it's not like a blood test where there's not a lot of technique necessarily involved, but this is, did you swab long enough? Did you swab far enough? Where in your illness were you?
Did your tube sit out in the sun all day until you got it to the lab?
Yeah, what kind of swab did you use? Was it one that you sourced from China that had no, FDA authorization?
Yeah, what kind of media is
all those things,
Yeah.
Yes, do you know what media is in the tube? Yeah, all those things. And so a negative result should be interpreted as a patient is less likely to be infected, not is not infected, right? And so how less likely that patient is to be infected depends on a couple of things, according to these authors. So one is what's called the pretest probability, which is how likely is it that the person in front of you was actually exposed to and would have this virus. So if this is a shut-in who only has one healthcare visitor a week who is gowned and gloved and masked, and they have a fever, it's very unlikely that that person is going to have this virus. But if it's a teenager who was out on a march and wasn't masked and with thousands and thousands of their best friends for a long period of time, then their pretest probability might be pretty high.
Right. And it's important to remember this is agnostic of any test result.
Yes, yes. So this is before you ever do anything. And then the second thing to consider is the sensitivity test, which I think most people who are in medicine understand sensitivity of the test, but that is that if the person is positive, if the virus is there, that you're going to get a positive test. And that sensitivity can vary pretty widely.
Very much so.
From instrument to instrument or
from
lab to lab.
To test. Yep, there's a lot of factors that affect it.
And then, so what they warn about is that when you're using a test that has low sensitivity and the pretest probability is high, so the person in front of you is very likely to have been exposed, and the test has a low sensitivity, that a negative result probably shouldn't be trusted or maybe shouldn't be trusted. So if the person in front of you clinically looks and sounds and breathes and acts like someone with COVID-19 who says, I was with 5,000 people who had COVID-19 and they have a negative test, we should probably not hang everything on the test being negative.
Where clinical judgment comes in.
Yeah.
Aren't the be all end all.
So even this, and we saw this, and even very early on in this pandemic, we would have calls into the shock of, I was on a tour bus in Milan, Italy, with other people who got diagnosed with COVID the next week in New York, and I have shortness of breath, fever, and cough, and the test is negative. And, so did that person have COVID-19? Probably. That is a high pretest probability. We didn't know the sensitivity of the test kind of result. So the conclusions of this particular paper are that the testing is only helpful, really, if the tests are highly sensitive.
Yeah, and high and low sensitivity is kind of relative. I mean, the example they gave in the paper is a low sensitivity test still has 70%. So when we say high sensitive, we mean definitely higher than 95%. That's definitely what you should be aiming for if you get to pick your test.
And so I think that's part of the problem for us as clinicians is that, we have no idea. When I was in practice and I ordered a test, I would never think to call LabCorp and say, what kind of platform are you running this Shigella test on?
And I mean, the other thing to keep in mind is, well, no test is perfect, and you have to balance sensitivity versus specificity. In this case, sensitivity is far more important. There's not a high likelihood of SARS-1 circulating right now. certainly as we get into the fall and we see more respiratory pathogens, specificity does come into play because you have to worry about cross-reactivity and that kind of thing. But for right now, certainly sensitivity is what you should be looking at. And if your lab is not able to provide that information, I would look for other tests because that should be widely available.
And then there aren't necessarily sensitivity studies on people who are asymptomatic and infected with COVID-19, so we really don't have a good measure of that.
Yeah, that's the challenge with the novel coronavirus, is that we're still learning as we go, and that certainly applies to manufacturers and people who are developing tests, as we're still trying to figure out, and we started with symptomatic folks because those are far easier to find. But certainly the need, especially as things begin to open up and testing is more widely available, to have a context and framework for how to interpret a test result in an asymptomatic person. It's very sorely needed.
Yeah. And then, and so the bottom line of this perspective was don't trust the unexpected negative test. And there is a clinical definition for COVID-19, so you don't have to have a positive test to diagnose someone with COVID-19. Again, if it looks and sounds and acts like a duck, it probably is. And so telling someone that, well, your PCR, this one PCR test was negative, so go home and your shortness of breath and fever is not from this is probably not using your clinical judgment.
Yeah, you can always consider retesting. That would certainly be a quick way to improve your, not necessarily odds, but...
Yeah, well, certainly the power of 2 negative tests is better than the power of 1 negative test, so that's helpful. We have had situations where someone has gotten a positive test and then for some reason has retested and been negative, and then people are, well, which one do we believe?
Yeah.
And generally we would say trust the positive because it's much less likely that we would have that.
It's very difficult to interpret these, especially the farther you get out when you do that second retest, because if someone was a low-level positive initially, by the time they retest, 2 or 3 or 5 days later, they could be below that limit of detection, and so it could have been a true positive, but if you test them far enough out into the infection or where they've recovered, they may test negative now, and that doesn't mean they didn't have it to begin with.
And can you talk about level of detection for a second? Because I don't think, I don't know, maybe it's just me, but as physicians, I never thought about it in terms like that before. I think it's helpful.
So the limit of detection, the short answer is you want that number to be low.
And the number is actual...
it depends on the test, but typically when it comes to a molecular COVID-19 test, they're talking about viral RNA copies per microliter or per mil. It depends on the volume, but essentially it's the limit of detection. So it's the limit that particular test can detect. How low can you go? So if you have 10 copies of the viral genome in your sample, can it detect it? If you have 5 copies, can you detect it? If you have 1 copy, so it really gets at kind of the analytical sensitivity of a test, and lower is generally better because it's a more sensitive test.
Yeah, and so it might make sense that an asymptomatic person would have a negative test if their viral load is quite low and it's below the level of detection of whatever test happens to be run. And some tests might need 25 copies and some might need higher than that.
Yeah, and that's what this paper is really getting at, I think, is sensitivity is really important, especially when it comes to testing asymptomatic individuals, because you need to be as low as possible in people that may have a lower viral load.
So, we're going to talk about, or Dr. Levinson's going to talk about determining thresholds for ruling out infection. So this is the graph that was in this particular study, and if you go online to this study, it's interactive, and you can slide these things around, which is kind of cool, but can you tell us a little bit about what this means?
Sure. I'm happy to walk you through the figure. I did want to kind of go back to what you mentioned about the FDA making sensitivity data available in the EUAs. And most of the EUAs, while they don't necessarily have sensitivity and specificity available, they have positive percent agreement and negative percent agreement instead of a sensitivity or specificity. And those numbers are calculated like sensitivity and specificity, but it's essentially an indicator that they used a non-reference standard as the comparator. So most standard, your 2x2 table. If you're calculating sensitivity and specificity, you're comparing your test against a gold standard. In this case, it's a novel virus. We don't have a gold standard for it. And so that's really, it's been a challenge, and we're starting to see more as more data is becoming available, and we can get a better sense of what a reference standard should be. But initially, and as these EUAs were approved, it was that positive % agreement, negative % agreement, because they were just comparing it to something. And that was the most you could kind of interpret out of it. So I agree it would be helpful to have, we're working on it. But going to the figure, I can kind of walk y'all through it, but I would recommend going to the site and kind of playing around with it. I think it really helps to have things kind of make more sense as you move things around. But essentially what this figure is showing is like how much can you trust a negative result. And if you look at the x-axis, that shows your pre-test probability. So as Dr. Fiskus mentioned, someone walks into your clinic, what are the odds, completely separate from any test information, of this person having COVID? And then you also look on your y-axis, and then that's really what your post-test probability is. It's, okay, given a negative result, how much can you trust it? Or the chance of them being infected if you have a negative result. And if you look at the kind of pink dashed line and that threshold, they noted that as considered not infective. And that's a threshold here, they set it at 5%, but it's kind of arbitrary, but it's really whatever level that you can reasonably assume someone's not infected. So you can make that 5%, you can make that 1%, it's kind of whatever you're comfortable with. And really what this graph is trying to show is if you compare two different tests with varying sensitivities, shown in blue 70%, which would be a low sensitivity test, versus a higher sensitivity test at 90%, it makes a really big difference based on the pre-test probability and the sensitivity of the assay, and really determining that post-test probability and how much you can trust that negative. So this graph really shows you two things. It shows you that test sensitivity matters, because if you use a less sensitive test, the one shown in blue with 70%, to get above that threshold of what you can reasonably assume someone's not infected, that's just at 15%. With a low sensitivity test. But if you use a higher sensitivity test, you can go all the way out to about 35% pre-test probability before you cross that threshold. So it really depends on the test sensitivity and how much you can really trust that negative. The other thing it shows you is that really that pre-test probability, and that's local transmission prevalence in your population, if that gets super high, if that's over like 50%, then testing becomes less and less important. It doesn't really matter if someone tests negative if say you're in New York City in February, when the prevalence is so high that, you don't necessarily have to trust the negative, because they could be pre-symptomatic, they could be asymptomatic. There's a lot of factors, and that's really where your clinical judgment comes into play. So what I liked about this graph is that it really narrows it down, and if you get a negative result and you're trying to figure out whether it's real or not, those are the two factors you have to consider, is your test sensitivity and the pre-test probability, or how likely this person is just coming into your clinic that could have it.
Yeah. I think it's such important context, and especially for some, and we deal with this with flu every year. We know that the rapid flu tests that a lot of us use have pretty high false negative rates, sometimes 10%, 15%, or more. Yeah. And so a positive, is usually a positive, although it's also visual interpretation most of the time, which sometimes just the well line looks like a positive. And in the case of flu, there's potentially a treatment decision to make. And so if you're not going to trust the test and you're going to treat the person, then it's probably just to tell them you probably have it and treat them if that's what you're going to do. But with this, there is no treatment, and what you're talking about doing is isolating this person for 10 days plus 72 hours from the resolution of their symptoms, which is not a small thing, and then also quarantining their entire household for 14 days from when that person's isolation period is over. So you would have potentially a spouse out of work for 3+ weeks because you are not sure that the negative is truly a negative and you really don't know. So I think it puts us in a really difficult position to say, well, you have a negative test, but I recommend that you go home and isolate and quarantine your household contacts for 2 weeks. It's a very difficult place to be. I think in the hospital it's almost easier because if clinically you look like you're a COVID-19 patient and you are acting like that clinically and you're deteriorating, then they're just going to treat you like that's what you are. But in an outpatient setting, it puts us in a much more difficult place, I think.
Yeah, test results are not absolute. They're your best guess at a point in time. And with a lot of these COVID tests, a positive is helpful, a negative, that's where your clinical judgment comes in.
Yeah, and this is where it gets difficult in some of the conversations that I've had this week about, say, universities that are talking about testing, requiring a negative test for their kids to come back to campus. And I had a conversation yesterday with some folks at a university, and he said, okay, here are the scenarios. So if you're requiring a test within 10 days of them coming back to campus, and they get it 9 days before they come back to campus, unless they're home isolated until they come back to campus, they could pick up this virus at any point in time, plus the incubation period still goes 4 days beyond when they come to campus. So a negative doesn't tell you anything. If they're positive, we don't know when they became positive. So this may be a persistent positive. Some people are persistent for 2 months, but we don't know, we know that they're not infectious for that long. It's just that there is still a level of detection of virus RNA that's there in their nasopharynx. And so how long are you going to keep a kid out of university because they had a positive test 10 days before they went to school? Or are you going to retest them and let them come back when they have a negative? And that might be next semester. Or are you going to not retest them, in which case they go to school and tell all their friends that they didn't have to have a negative test and they knew they were positive before, and now what do you do when those parents absolutely go nuts on you for doing that? So and then there's all the false negatives that you're not picking up in a population of 10 or 20 or 30,000 students.
Yeah.
That number is probably significant.
Oh, definitely. One thing to keep in mind is the sensitivity or specificity if you can get it, but even if it's that positive or negative % agreement, those are generally based on symptomatic or spiked samples that you know should be positive or negative.
Yes.
Or if they're looking at patients, they're generally symptomatic. Very few of them really have begun to look at asymptomatic and get kind of the performance characteristics of these tests in that population.
So, so in the case of, let's say you have a student population of 10,000 students that you're going to require to have testing, the cost of that is about $1 million. And so to spend $1 million, no matter whose pocket that comes out of, whether that's the insurance companies paying it or the government paying it or the individual paying it out of pocket, to not know if the people who are actually coming onto campus are truly positive or negative and not be able to act on that. And unless what you plan to do when all those students come to campus is keep them in a bubble and never allow anyone to go off campus or come on campus, it's really pointless to do testing in that way. So what might make more sense is to do some targeted surveillance type testing where, okay, today we're going to test this frat house, everybody's going to stay put for a day, have fun, and then we're going to come back and quarantine you when we find out that 5 of you are positive because you're all in the same house, versus, this dorm floor or whatever. And then obviously testing everyone who presents with symptoms and doing contact tracing so that those people can be isolated and quarantined and having a good plan for that.
Completely agree.
So I hope that was helpful, a little bit of a deep dive, and maybe some folks can even share this webinar with folks that need to understand a little bit more about testing. So I did want to ask if you have PPE at this point, because we didn't have PPE, then we started to get a little more PPE, and now we're moving towards not having PPE again on a national level, it seems like. So it looks like folks are still having trouble with gowns and face shields, and N95 masks, but surgical masks and gloves folks might be okay with. So if you don't know what I'm talking about, go to www.menti.com. I should probably have said that. Enter 389028. 389028 is the code there. And then you can answer if you use PPE, is it adequate? gloves, masks, N95s, gowns, and face shields. And so if you have ever requested PPE through the Survey 123 link to get PPE from TEMA, you can answer in here. So generally we have had folks that have requested PPE from TEMA and been able to get those supplies within about 7 days. So I'm going to share that link with you in a second for those of you who might be excited to hear that. They have face shields, gloves, gowns, masks, N95s, surgical masks, booties, foot covers that you can request, and they will ship them directly to your office. There's not a charge for that, and they're doing that because they know that the supply chains have not yet opened up, especially for small practices that might not request the kind of volume that McKesson wants right now. So you can order that through TEMA directly, and they'll send that to you. So it's great that about half of you have ordered through Survey 123, and about a third of you have not yet. And then for those folks who have ordered through Survey 123, how long did it take for you to get those supplies? So we'll give this a couple of seconds. So for those who have ordered, it looks like they're all saying that they did receive their PPE within 6 to 10 days, which is awesome. Many practices have struggled with being able to get that. There's some folks who got it in 3 to 5 days. So if you've waited 2 weeks and you still have not received your PPE, go ahead and put in another request into that Survey 123 link. There's various reasons why you might not get something. They do ask for your 2-week burn rate estimate, and they're not going to send you more than what they think you're going to burn through in 2 weeks. So if you ask for 500 N95s and you are a 2-physician practice, you are not going to get 500 N95s. You probably won't get any N95s. They're probably just not going to fulfill your order at all. So if you go in and ask for a reasonable quantity for your practice and what you actually need for a 2-week period, you can go back in and reorder every 2 weeks, and they will continue to drop ship those to you. So ordering small quantities are much more likely to get fulfilled and filled quickly. My former practice got their PPE in about 48 hours, which was amazing. Also, it's possible that if they're low on a particular item and you have that in your order, usually they do send out whatever they have to fulfill, but if they're holding it for some reason, you might want to go back in and just order one specific type of thing that you need and see if you can get it more quickly that way. But I do share this feedback with TEMA so that they can see what the turnaround time is looking like, and I share this with them every week so that they know what's happening. But for the most part, they're doing a pretty good job. This is the code for that. I always feel silly reading this out loud. https://arcg.is/1 capital L little I capital C, capital P. I don't know why they just couldn't put like PPE now from TEMA.com or something, but they didn't. And then you have to have the passcode 8362. So there's a survey there. They ask for who you are, where you are, what kind of organization you are. The last time I checked, they didn't have the actual medical practice listed as an option, so you can write that in as other if you don't see what you are there. And then request that 2-week supply and then go back in a couple of weeks and request again, and they should be able to keep sending you that until these supply chains open back up. Okay. Oh, gosh, we talked a long time and didn't get to a lot of questions, so let's get to those real quick. And the first one's about labs, so nope, the first one's not about labs. Well, it is kind of. Okay, so how will the state's capacity to test be impacted when all these businesses and nursing homes start testing weekly? So there is a mandate for the long-term care facilities, the nursing homes, to test their employees every week, and I don't know when that ends. I haven't heard. And so that has definitely impacted the state lab from a capacity standpoint.
Yeah.
There's been a lot of those tests that have come in. But we also process tests through labs other than the state public health lab.
Yeah, and I think all of them are potentially reaching their capacity limits too, though we're all, I think, trying to get more reagents and instrumentation to increase our capacity. I think most directly, the impact will be felt with turnaround time, in that you may see longer turnaround times from when you send your sample to the lab, our lab or another, and when you get results.
Yeah. And that worries me for fall too, because then we start running a lot of other types of tests on the same types of machines. So
yeah.
flus and respiratory viral panels that may compete with any lab's ability to turn around COVID testing.
Yeah, and that's where I think the multiplexing assays will come in. That's something our lab is certainly looking at, and we'd like to be prepared to have those tests in place for the fall. So we're not having to double book our instrumentation, that with one test we can look for all those fun bugs.
Yeah. Could you discuss testing asymptomatic patients before non-essential surgery? So a lot of the hospitals are testing folks before surgery. They'll do, some of them are doing an antibody assay first, and then if the antibody is positive, then they're doing a PCR test to see if that is also positive. I understand why they're doing it. You know, they're trying to protect themselves, their hospital, their employees the best that they can, but obviously a lot of flaws in the process.
Yeah, especially I understand the risks with, aerosol generating procedures, that kind of thing. But again, that's where test sensitivity really comes into play. So if you're working with your lab that you already have a relationship with and you know they're doing a PCR, that'd be great. For some of these more wave point of care tests that do have slightly more questionable sensitivity, I'd be really hesitant and concerned to employ those in kind of a screening process.
Yeah, yeah. Someone's asking for the reference to the article, so I went back to that slide there, and that reference is at the bottom, which is not super easy, but you can probably just put in Woolachin and the title there in a Google search, and it'll probably come up. Is the physician support only for physicians, or can nurse practitioners, PAs, nurses, or techs call? So that's in reference to the physician support line that I talked about for psychiatric assistants. So I Googled it, and what it says is the physician support line is a peer-to-peer support line for physicians by physicians. It's open to U.S.-based DO, MD, international equivalents, and at the attending fellow, resident, intern, medical student, or research level. You do not have to be currently practicing medicine to speak to our volunteers, but it does appear to be at the physician level or medical student level. So, and then as far as other resources, probably the easiest resource is going to be to look at the back of your insurance card that has a behavioral health line on the back of it, and to call that to be able to get assistance, unless it's an emergency, in which case you would want to call the mobile crisis line to have them talk to you, but probably the best way to do that.
I think I can take the next four.
Okay, go ahead.
The next question is, the front page of the Tennessean 2 days ago showed a person getting a test done incorrectly. It was not nasopharyngeal. Can anyone teach how to do this correctly? So I do want to mention nasopharyngeal is not the only specimen type that can be collected for a COVID-19 test. It does vary a bit by test, but generally speaking, oropharyngeal, nasal swabs.
Can be mid-turbinate,
yep.
Anterior nasal.
Yeah, you can get into washes and aspirates, and you can do lower respiratory samples too. So just because it wasn't showing in nasopharyngeal or NP doesn't necessarily mean it was incorrect. The next question is about pooling samples, and I could probably fill an entire webinar about this if you want to invite me back. But in a nutshell, it is being considered and put into practice in other states that I'm aware of. There's a lot of factors to consider in it. Certainly, it's a cheaper way to do testing because you can pool things. So if your reagents are limited, that's one way to get more bang for your buck. The challenge, though, there's multiple. One with billing is, if you're pooling all these into one test, do you charge all those people for one test?
That's what this is. This is like a whole bunch of nasal swabs that are washed off into one test tube?
Yeah, you literally pool them all together. That's at least the laboratory interpretation of pooling. The other thing you have to consider is sensitivity will go down. If there's inhibiting factors, if you're putting 10 people's snot into one tube. You know, if one person has something that could inhibit it, you're inhibiting the reaction for all of them. The other challenge is, the idea is you pool them together, you do one test. If it's positive, then you retest all of them individually. So that's where you get kind of the more bang for your buck in terms of reagents. You can use them further. The challenge, though, is, again, prevalence. And if it's past a certain threshold in your population, it doesn't really do you any good if you then have to retest everyone anyway. So then you're actually doing extra tests. So like I said, I could talk your ear off about pooling. It's got its strengths and weaknesses. I don't think it's going to be put into practice in Tennessee anytime soon, but it's definitely on our radar.
It doesn't sound like a lot of strengths. I mean, if you had one positive out of 200 that were pooled together, the chance of detecting, you know, that's going to be at such a low level of detection per
potentially. I mean, I think the benefit is when you're at your testing capacity and you're finding ways to increase testing availability, this is one way to do it. You can multiply by 10, and suddenly that's your capacity. So there are some benefits to it. You just have to be really thoughtful in how you do it and kind of weigh those positives and negatives. The next question is, what is the sensitivity and specificity of the Tennessee Department of Health COVID test? And the quick answer is, it depends on the test. At least at the Public Health Lab, we employ multiple COVID-19 test platforms, and the sensitivity and specificity is going to vary by platform. So it's really test specific. Next question is, what is the specificity of PCR? False positive. So really, I mean, so specificity is really, you know, the odds of someone being negative if they truly don't have COVID-19, and it depends by test. So it's not just test method, like PCR versus antibody versus antigen, but it's really going to be specific to the test. So you're going to have to look that up because it can vary greatly.
There's some of the, well, this particular article said some of them are down to about 70% in some cases with some platforms, and then some they cited were in the 90s.
Yep, it definitely ranges, and then you have to keep in mind most of those are with asymptomatic people. That's what those numbers are based on, so it could be very different in an asymptomatic population.
And there's probably close to 100 different PCR platforms at this point.
Yeah.
Those are just the ones with EUA.
Yeah.
Who knows what else is out there.
Yeah. All right. Yours.
All right. Have any small healthcare practices been identified as clusters of COVID-19 cases? Not familiar with any healthcare practices that have been identified as clusters. Couldn't tell you even if we knew, but I don't know that. What we've seen are the nursing homes that, and those are posted on the website. Updates on saliva testing. There are getting to be more and more consumer-based saliva tests. The first was Rutgers that came out. That is not consumer available, but there are some other companies now where they have direct-to-consumer testing for saliva.
There's a lot of work being done kind of more on the research side of, you know, the sensitivity of the saliva versus an NP sample or another sample. Certainly as you move through infection, the viral load in the saliva is going to change. And when you consider, again, asymptomatic or pre-symptomatic folks, you definitely have to take that into consideration with your test.
Next one's yours.
All right. Understanding there's little clinical value at this time, what is the best test or lab available for antibody testing? Thank you for recognizing there's little clinical value at this time. Essentially, there isn't a best one. I would start with the ones that have emergency use authorization from the FDA. That's a good place to start, but best is pretty relative at this point. Again, starting with something that's been at least evaluated by the FDA, and if you feel so inclined, you can look at the performance characteristics and get a sense of how thoroughly they did evaluate the performance of their test in a variety of situations, whether they spiked samples, whether they used known clinical samples in hospitalized patients or non-hospitalized patients, even greater if they could do it in asymptomatic people. Those are really kind of the things you have to look for when trying to figure out what the best test for your clinic or facility is.
And so just like Dr. Levinson can do hours and hours of webinars on pooled specimen testing, I can do hours and hours on the challenges of opening schools in the fall. So the biggest thing that schools need to do to prepare is to be able to pivot between in-person and virtual learning, because they are constantly going to have kids that have febrile respiratory illnesses where they're going to need to be kept out of school probably along the lines of a COVID-19 isolation period of 10 days plus 72 hours of resolution of symptoms, because you can't test your way out of a person who looks to have COVID-19. Having negatives isn't super helpful. So I know the schools are all really scrambling to put together what is an incredibly challenging logistical problem to solve it as best they can. Everything from how do you get kids to school on a bus when there's bus driver shortages and overcrowding on buses to begin with, to how do you temperature screen hundreds of kids at a time, and how do you socially distance little kids and have them wear masks that they won't wear, and teenagers who aren't going to want to comply with that. And it's a never-ending list. We've worked closely with the Department of Education to try to get that guidance right, and there's just so much, and really the year-round schools are starting back in about 4 weeks. So this is not a lot of time, and we're also as a nation continuing on an upward trend of our cases. As a state, we're on an upward trajectory, and now we're going to throw colleges and K-12s in the mix. So it's going to be a very interesting and I fear very troublesome fall. What kind of guidance should dental offices follow? Are they eligible for that PPE assistance? So there is, I'm not a dentist and I don't pretend to know everything that dentists should follow, but there is CDC guidance on that. So if you go to cdc.gov/coronavirus, put dentist in the search bar that I just did, there is guidance there, and you can request PPE through that link for TEMA. I can't tell you where the dental offices are in the priority list when I know that there are community health centers and nursing homes and physicians' offices that need PPE, but you certainly can put that there. How can we determine if a nursing home is compliant? That is a great question, and I don't have an answer to it. That is managed through the regulatory part of Tennessee Department of Health, and that is something that I can get an answer back for you next week. Is there an assessment of risk for allowing visitors, some of whom will be carriers, into nursing homes with relative noncompliance of a portion of the population with preventive measures? It seems very risky to open nursing home doors. Yes. So it is part of that requirement that they screen visitors for symptoms, that they check their temperatures, and they still have to remain at a distance from the nursing home residents, whether that's behind a window, like a plexiglass kind of thing, or just physically distanced from them. And it can't happen in communities where there's high transmission. But of course, people could be coming from other areas of the state or the country to visit their loved ones, so it's definitely a challenge. I think the governor was trying to balance the needs of families to be able to visit with their elderly loved ones versus trying to find ways to mitigate the risk as best he could. And we're going over, and we know that some of you may need to drop off, but we're going to go ahead and answer the last few of these questions that are here. Someone did just comment that they are a dentist and they did just get PPE from TEMA. So there you go. Thank you, Dr. Dentist, who answered that.
Great. I can take the next question. I'm going to infer some of the words here. Why is it taking the FDA, I'm guessing, so long to validate point-of-care serology tests? I know one company that submitted their kits over a month ago and no response yet. Could happen in half a day with the number of cases the U.S. experienced. Any explanation? It's not like there are thousands of different kits to validate. I'm not sure if that last part is sarcastic or not, but my general answer would be I think the FDA is pretty busy right now. They've been very busy. They were kind of swung in one direction and then went to the other, and I think they're trying to find a middle ground. I know initially with the PCR and molecular tests, they were very strict about what tests they could be used and who could do that testing. Beginning with like the CDC assay and how that got distributed to the state labs, and there wasn't a lot of clinical testing that could be done initially. That's loosened up certainly, but I think then they swung in the other direction, and anyone who wanted to make a serological test could and distribute it. and that kind of flooded the market with a lot of these lateral flow tests that are really questionable at times and really just a moneymaker. You probably have a better chance of flipping a coin and diagnosing someone rather than using one of those tests. So where are they at now? I'm not 100% sure, but I think they're trying to aim for that middle ground. And generally, the companies and the manufacturers are the ones performing the validations of these tests, but then they have to submit that data to FDA for review, and that's how you get that emergency use authorization. And that does take time to review the data and make sure things are correct, because that EUA carries some weight, so they want to make sure they do it right. So,
well, then there's the whole other clinical part of that, so even if you have a valid test, what does a positive IgG or IgM even mean in the face of this?
Definitely.
So we know that not everybody makes IgG to COVID-19. We know that it comes at various times in the infection, some as early as 2 weeks, sometimes it's 2 months. So having a positive, if it's not a specific test, may not tell you anything about COVID-19. If you have a negative, it doesn't necessarily rule out that you have antibody to it.
Yeah, I know they're focusing their efforts on starting to compare the different serological tests to see how they do against each other, and that should be able to provide some more information on the tests themselves and how to interpret the results, and also hopefully help clinicians when it comes to picking a test.
Who's paying for the long-term care nursing home testing? Right now, the state is paying for that. I believe using the federal allocation of COVID-19 funds that came down from whoever that is who gave it to us, HHS or probably somebody like that. And we don't know, we have not heard how long the state is going to continue to pay for those. And there has been, on the governor's brief this week, there was mention of testing private companies, although I have not heard what the arrangements are around who pays for that or whether we just help facilitate it. So I can't comment on why the government has or has not decided to pay for private company testing. And then the last question we have is the conclusion that universities remain closed until everyone is vaccinated? Of course not. So there is going to have to be some back and forth and some probably hybrid models where freshman classes that might have had 200 people in them get virtual testing, or virtual instruction, and smaller classrooms. Maybe if you need lab, you can't do an anatomy class very well virtually. I guess you can, but it's just not the same. And so there's going to have to be ability to instruct people in person and instruct people virtually, and be able to continue instruction for people who may be exposed and have to quarantine, so that they're not missing 2 weeks of their classes, because college is already stressful enough without booting somebody out of class and having them have no opportunity to get the instructional materials they need. So, no, university needs to go on, and we got to find out how to do it and mitigate risk as best we can, just like with everything else that's happening. But I think the point was that there probably isn't much utility in mass testing everybody before they come on campus. So that's it for the questions. I want to remind you of the webinar that we're doing in the immunization program next week on Thursday, Repairing the Damage, Restoring Immunization Rates in Tennessee. We're going to talk about different strategies to get people vaccinated again, as our immunization rates, at least in the month of April, were down by about 39% in children, which is terrifying. So there's the link for that. Please sign up, and we will see you all next Friday. Next week, so Dr. John Benitez, he's a physician here at Tennessee Department of Health. He is a toxicologist and also an expert in emergency preparedness. He just came back from a 7-month deployment to the Middle East. He's a military reservist and was over there when coronavirus hit. So was responsible for helping with the coronavirus response in Iran and Iraq and Kuwait and all of those other countries in the region, setting up hospitals. And so he's going to be on next week talking about his experience in the Middle East. And then the week after that, we will have Dr. Paul Peterson, also from Emergency Preparedness, who's going to tell us about the alternative care sites that have been set up. So we will see you next week. Have a great weekend.